Welcome back to our discussion. I'm Edward Abrahams, president of the Personalized Medicine Coalition and one of the co-conveners of Turning the Tide Against Cancer Initiative. For those of you who don't know us, PMC is a membership-based education and advocacy organization dedicated to advancing personalized medicine across all indications, having organized all of the stakeholders in healthcare. If you're not a member of PMC, I invite you to join us. As we gather back in the amphitheater for our afternoon session, I want to take a moment to thank our advisory committee members, several of whom are with us today, for their personal contributions over the past 5 years, for providing their expert guidance as we work to bring the community together to address some of our greatest challenges in oncology and especially in policy development. I'd like also to recognize our supporters for today's conference. Their logos should be on the slide behind me, and maybe there they are. These organizations from advocacy, academia, media, and industry have made this conference and this initiative indeed possible. It is my honor to be here today among the thought leaders in cancer as we work to identify patient-centric solutions to cost and access issues the field of oncology faces today and which we discussed this morning. During our morning session, we heard from a variety of stakeholders on what some of the solutions might look like. And I would hazard to say that every speaker across all the stakeholders emphasized one thing, and that is to put patients first. We're going to continue our discussion this afternoon based on what the solutions in implementation might look like. Regarding implementation, I thought it might be useful to focus on the difference between personalized and precision medicine. While we use those terms interchangeably, there are differences. And to illustrate those differences, and to illustrate how important patient-centeredness is, I want to share with you an exchange between a patient and his oncologist that comes from When Breath Becomes Air by Paul Kalanithi. You may know the book because it's a best-selling account of a cancer patient. And it's written by a terrific writer and also, I must tell you, also a neurosurgeon. So he has some familiarity with medical concepts. He illustrates in his book not only the advances in research and development and in cancer care, many of which were discussed this morning, but he also talks about the differences, without using the names, of precision and personalized medicine. So bear with me while I share with you this encounter between a neurosurgeon and his oncologist. After more pleasantries, we settled into a comfortable discussion on the state of lung cancer research. There were two paths forward, she said. The traditional method was chemotherapy, which generically targeted rapidly dividing cells, primarily cancer cells, but also cells in your bone marrow, hair follicles, intestines, and so forth. Emma, that's his oncologist, reviewed the data and options, lecturing as if to another doctor, but again with the exception of my mention of any Kaplan-Meier survival curves. Newer therapies have been developed, however, targeting specific molecular defects in cancer itself. I had heard rumors of such efforts. It has been the holy grail of cancer work, and we heard about some of them this morning. And I was surprised to learn how much progress had been made. This was 2 or 3 years ago. These treatments, it seemed, had led to long-term survival, albeit only in some patients. Most of your tests are back, Emma said. You have a PI3K mutation, but no one's sure what that means yet. The test for most common mutations in patients like you, EGFR, is still pending. I'm betting that you have that mutation, and if so, there's a pill called Tarceva you can take instead of chemotherapy. That result should be back tomorrow, Friday, but you're sick enough, I've set you up for chemo starting Monday in case the EGFR is negative. So that's essentially precision medicine. I immediately felt a kinship. With chemo, our main decision will be carboplatin versus cisplatin. In isolated studies, head-to-head, carboplatin is better tolerated. Cisplatin has potentially better results, but much worse toxicity, especially for the nerves, though the data is old, and there's no direct comparison with our modern chemo regimens. Do you have any thoughts? I'm less worried about protecting my hands for surgery, I said. There's a lot of things I can do with my life. If I lose my hands, I can find another job or not work or something. She paused. Let me ask, is surgery important to you? Is this something you want to do? Well, yes, I've spent a third of my life preparing for it. Okay, then I'm going to suggest you stick with carboplatin. I don't think it will change survival, and I think it could dramatically change the quality of your life. Do you have any questions? In other words, she's introducing him to personalized medicine. What are his values? She needs to know to prescribe the right treatment. She seemed clear that this is the way to go, and I was happy to follow. Maybe I began to let myself believe perhaps performing surgery again was a possibility. I felt myself relax a little. Can I start smoking? I joked. So, we exist in a time where we are indeed on the verge of advances that can change the way we diagnose, prevent, and treat cancer. But it will require, as we've heard today, patient involvement in every phase, from research and development to care and delivery.